Good evening, ladies and gentlemen. On behalf of the management team of the Faculty of Medicine and Health Sciences, I bid you a warm welcome to the inaugural lecture of Professor Nando Ferreira, and I trust that you will enjoy this evening with us. Please stand for the entrance of the academic procession.
Please take your seats. Good evening, colleagues, ladies and gentlemen. For those of you who don't know me, my name is Nico van Pittius. I'm the Vice Dean for Research and Internationalization of the Faculty of Medicine and Health Sciences of Stellenbosch University. It's my distinct pleasure on behalf of Stellenbosch University to welcome you all here this evening. On this auspicious occasion, the professorial inaugural lecture of Professor Nando Ferreira. A special word of welcome to our Deputy Vice-Chancellor for Learning and Teaching, Professor Dinesh Ramjugannath, Professor Ferreira's wife Yvette and his children, Logan, Connor and Kenzie. Those are the people who share him with his profession and academic career. His parents, Dr. Ferreira and Ms. Leonie Ferreira, Prof. Jacques Touwe, the head of the Department of Surgery and Surgical Sciences, and Dr. Marlies Berger, the head of the Research of Orthopedic Surgery, and all the consultants and registrars who works with Prof. Ferreira. We know that academic progress is not possible without an entire team who works with and together with you. And of course, then, obviously, our inaugural lecturer himself this evening, Professor Ferreira. Thank you for being here. Welcome also to all other family, friends, colleagues of Prof. Ferreira who are joining us here in person tonight and also online, including colleagues from Stellenbosch University and other guests from outside the university. So inaugural lectures is a central part of our academic calendar, a very important part of our university, and they epitomize this pivotal milestone in any academic's journey. That moment in the academic's career as a scholar, as a researcher, as an educator, where they are recognized for a lifetime of academic achievements and pursuits that led to their ascent to the rank of full professor. It provides the individual not only with the opportunity to present their academic work, their research interests, their passions over many years in education and teaching and research, and their contributions to the field of study, to the university community, and also to their family and the wider public. But it also affords the audience to get a glimpse into the fabric of the person's character and the path that they have traversed to attain this remarkable distinction. Today we gather here to celebrate not only the remarkable achievements that have propelled Professor Ferreira to his well-deserved elevation into the full professorship, but also to honor the essence of intellectual curiosity and academic excellence that characterizes him and our institution. As such, this event is really a special occasion for all of us, not only for Professor Ferreira, but all of us here this evening. We are delighted that you've chosen to be part of this sharing, this celebration this evening, in sharing the significance of this occasion with Professor Ferreira. I would like now to hand over to our Dean, Professor Elmi Miller, to please introduce the candidate. Thank you very much, and I hope you enjoy the evening.
Ladies and gentlemen, esteemed colleagues, friends, it's my absolute pleasure to introduce Nando Ferreira for his inaugural lecture tonight. Someone who is not only a giant in the field of orthopedics, but also a man of many fascinating layers. Promoted to full professor in 2020, Professor Ferreira has been leading the clinical unit Tumor, Sepsis and Reconstruction at Stellenbosch University since 2016. His work in musculoskeletal infection and post-traumatic limb reconstruction has set new benchmarks in patient care and in treatment innovation. Professor Ferreira's academic path is also very diverse. With a BSc in Human Physiology and Genetics and a medical degree from Stellenbosch University, he furthered his orthopedic training at the University of KwaZulu-Natal. His expertise was enriched by specialized training in the Ilizarov technique during a visit to Russia in 2011. His doctoral research, completed in 2015, focused on innovative treatments for tibial non-union, making a lasting impression in the field. As an educator, Prof. Ferreira has supervised over 20 master's students and 5 PhD students, nurturing the next generation of orthopedic professionals. He also directs the Limb Lengthening and Reconstruction Fellowship at Stellenbosch, attracting surgeons from across Africa and the globe. His efforts have secured 8 million rand in grants, advancing limb reconstruction techniques as well as regenerative medicine. Beyond academia, Professor Ferreira has been actively involved in the South African Limb Lengthening and Reconstruction Society, serving as the president of this group from 2016 to 2023. He's also the editor-in-chief of the South African Orthopedic Journal. He continues to shape orthopedic scholarship on a national level. He also has over 150 peer-reviewed articles, 8 book chapters, and his contributions to this field has been widely recognized. But he is also not only a scholar and a surgeon, he is a man with remarkable general knowledge. He's the kind of person that Faiki told me is a dream to have in your pub quiz. He is a biomechanics enthusiast. He has a passion for restoring old motorcycles. And when he is busy with orthopedic surgery, you might find him in his garage breathing new life into a vintage bike. He also deeply cares for his patients and has been a mentor for his registrars who have performed very, very well under his guidance. He's devoted to his family, cherished by his wife, Yvette, and his kids. So without any further ado, please join me in welcoming Professor Nando Ferreira, a man whose expertise, compassion, and zest for life make him a true inspiration in the orthopedic field.
Thank you very much for the introduction. Just want to get to the... Okay. Thank you very much for the invite. Thank you very much for the promotion to full professor a couple of years ago already. In getting the invite to come and present here, I had a long, hard look and thought about what I was going to talk about. I went and had researched a little bit on what an inaugural lecture should be. So when you become a full professor at university, the inaugural lecture is supposed to profess your knowledge to the layman, and it's supposed to be open to anyone to join and come and sit and listen to. So I decided I'm going to tell my story of how I became involved in limb reconstruction, and I'm going to weave a couple of other stories into my story, where I started and where I'm now, and hopefully where we're going to end up in the future. So I'm going to start the lecture with the journey of Mr. JF. Now, the type of patients that I see all the time and present in my clinic all the time. Mr. JF is a 50-year-old male. He presented to my unit at a clinic in 2017. His history is that he sustained a gunshot injury when he lived in Angola. He's from Angola originally, in 1996. And this left him with a fracture to his left femur, and he developed a hypertrophic non-union. I'll explain that just now. In his journey, he has been seen by multiple orthopedic surgeons over the preceding 20 years. all of which advised him an amputation. So, this is not advancing. Okay, so this is the 3,500 kilometer journey that he made, eventually ending up in Cape Town. And like he said in his own words, he stopped along the route at many different hospitals, seen many different surgeons in an attempt to help him after this injury that he sustained. Eventually making his way to Cape Town and got the same message in Cape Town as well. So this is the X-ray of his left femur when he presented to us. And you don't have to be an orthopedic surgeon to know that there's a lot wrong there. What you're actually looking at here is a pseudoarthrosis or non-union of the femur. And it's pseudoarthrosis is Latin for false joint. So there's movement at that area. The bone never healed. Subsequent to the gunshot, you can see some evidence of gunshot bullet fragments that's still retained in the soft tissue. You can see his knee joint. But this non-union is mobile, which means that it doesn't give him a stable leg. So for 20 years, he couldn't walk. He used crutches or a wheelchair to get by. And he presented to my clinic for the first time in 2017. And his words were, everyone that I've seen has told me that I need an amputation because there's no way that they can treat this. I'm now ready for my amputation. I've come, I can't take it anymore. Please, can we just do the amputation? This is the first time that I saw him. So I didn't have the pleasure of seeing him earlier. And I said, well, now that you've made the decision for the amputation, there's something we can try. It is going to be a Hail Mary try, but there's something we can attempt. So we sat and we discussed with the patient and planned a lot of things. And the idea at the end is we're going to go in and we're going to cut out that non-union, whole piece of bone. All right? Easier said than done. The femoral artery, which is the main artery going down to the leg, is draped over that and will have to be dissected off that non-union. And the patient has to understand that if I damage that artery, it was going to be an amputation anyway. So the plan was we're going to go in, we're going to resect where we are marked, we're going to acutely shorten that leg, and we're going to fix it in that position. Okay, so that's the plan. We went to theatre, and that's where we ended up after theatre. So we managed to resect that non-union, fix him short, and you can see he is now stable, but he's now 10 centimeters short on that left side. But as part of the plan that we had from the start is once this newly made site starts to heal, we're going to go back to theatre. We're going to change that nail to a length nail, which is a very specific device. And we're going to lengthen that leg out again and give him the length back that he lost because of the surgery that I did. Okay, and this is us a couple of months down the line, and you can see the lengthening there, and if you look very carefully in that gap, you can see new bone formation in that area. This is now fast forwarding a couple of months later, and the nail has now been removed. You can see the femur is now healed. It is out to length, and he's overall 1 centimeter still short because of the procedure. And this is him now after the nail has been removed, walking without crutches for the first time in 20 years. So, Rudolf Venter, who's here in the audience, he works with me, and he often calls me when we see a patient that we are lengthening or doing a bone transport, and we see this bone formation. And he goes and says, look at this. This is like magic happening in front of our eyes. Now, Arthur C. Clarke said, any sufficiently advanced technology is indistinguishable from magic. Now, this is not magic. This is the field of limb reconstruction, and the field that I've been infatuated with since I got to learn about it when I was still a resident. So I want to tell you my journey, my travels, how I have changed in my outlook, in my approach, in limb reconstruction, and what I've received from this field, as well as hopefully contributed to it as well. So I'm going to start off with this x-ray. And if you ask any of the registrars now, or I hope they would answer correctly, how you would treat this stiff hypertrophic tibial non-union, the answer that would come from most of the guys would be you distract. Okay? Contrary to popular belief, you actually put a distracting force on it and try and pull it apart. And by doing that, you actually see new bone formation forming in that defect, and you can get that bone to heal. Okay, like I said, most of the registrars, just nod, would answer that if I asked them now. Yes, so they all nodded. Yes, so that's what they would answer. But this was not common knowledge not so long ago. In 2015, I wrote a paper and I submitted to the Bone and Joint Journal in the UK with this technique and the outcomes of my approach. This is the first line of the reviewer's report that I got back. So after submission, it's like you have a review back, and this is literally the first line of a multiple page document taking all my research apart. Okay, can't believe this. It goes against everything I've learned. How can you achieve bony fusion in an established fibrous tibia non-union by applying distraction? You need compression first or bone graft. Okay, these were experts in the field reviewing my paper. So, this was 2015, and I'm going to come back to this again later on. Now, limb reconstruction as a subspecialty in orthopedics is probably one of the youngest orthopedic fields. It's no in the West, no older than 25, 30 years maximum. The first time that ring fixators came to South Africa was 96, 97, I think. So it's a very, very young field, a very rapidly growing field. But in the South African setting, in the setting of the Western world, it is still a very, very young field. It is progressing very quickly. We now have 2 international dedicated journals specifically focusing on limb reconstruction only, where if you go and count how many spines or arthroplasty journals there are hundreds. But we now have 2 dedicated journals to limb reconstruction, and there are multiple limb length and reconstruction societies popping up all over the world. The largest is the LLRS, which has got a North American, South American, Indian, subcontinent branches. But there's the British Limb Reconstruction, the New Zealand and Australian Limb Reconstruction Society, Egyptian Society, and since 2015, we had the South African Limb Lengthening and Reconstruction Society as well. And this helps by getting people together. We've got congresses specifically focusing on limb reconstruction and sharing ideas and adding to this rapidly growing field. Now, like I said, my journey started when I was a registrar in Pietermaritzburg in 2006. Started as a first-year registrar. And about 1 year into my training, we had a spate of really bad tibial plateau and tibial pillar fractures come in. And sorry for the picture, but this is the type of soft tissue looks like over a bad tibial plateau. So this is a tibia fracture around the knee. And often these injuries look like this. So the soft tissue took a very, very bad damage at the time of the injury. Now, how you would normally treat these is to do an open reduction, meaning you make incisions, you put the pieces of bone together under direct vision, and you would put plates on the inside. Now, you don't need to be an orthopedic surgeon to realize that incising through this soft tissue is not going to be good for the patient, and we often have problems with wound breakdown, infections, and patients ending with amputations because of the condition of the soft tissue more than anything else. Now, I saw these cases and I said, there must be a better way of doing this. We used external fixation, but we used monolateral external fixation, meaning it's pins that go from the outside through the skin into the bone and holding it together with a bar outside to try and hold everything. The problem is that the biomechanics of a monolateral X-fix isn't good for managing this injury specifically, because it is spanning the knee joint and it is spanning a very bad fracture close to the knee. So that wasn't the answer. Also, although the infective complications were reduced, the malunion or deformity complications were not. So at that time, I was a senior registrar. I went to my head of department, Mrs. Sonogi, at the time, and I said, I've been reading a little bit about these injuries and came across a technique of using Ilizarov all-wire circular frames. And I want to start doing that for these patients. At the time, there wasn't a single surgeon in the whole of the province of Natal that was doing circular fixation. No one. And I have to say, to his credit, this is a second-year registrar coming with this idea, and he said, well, go for it. He said, find the first case, show me your planning, show me the case when it's done, and we'll see how it goes, and then we'll take it from there. So that's what we did. So myself, with the registrars in the department at the time, we started with the old school stainless steel Ilizarov rings that we found lying in cupboards. Smith & Nephew still had these. And we started doing all-wire circular frames for these cases. Don't get me wrong. This wasn't haphazard, shoot from the hip type approaches. Before I did the first case, I read everything I could find. Any literature, any textbook, anything I could find, I read before I did the first case. My planning, I spent hours planning cases before they went to theatre. And if you came into my theatres at that time, the wall would look like that. I would have pictures stuck up on the walls of exactly what I'm going to do, where I'm going to place pins, where I'm going to place wires. Even the sequence and the numbering of those pin and wire placements were all mapped out. So they spent hours planning these cases. I remember the first frame that I built, and those days I built the frames next to the patient's bed. I spent 2 hours putting the frame together, taking it apart, putting it together again, to make sure that I'm not going to impede myself with all the wires and going to run into space problems. So I spent a lot of time. This is another case that did it a couple of months later, and you can see the patient's face really excited for his operation, getting a circular frame on his leg. Yeah, like we said, when I was in Russia, one of the people asked, well, isn't this uncomfortable for the patient? And the Russian just looked and said, yes, it's uncomfortable for the patient, but it is comfortable for the bone to heal. And that is the priority here. Anyway, so in these days, spent a lot of time next to patients' beds, designing frames, building frames, and then going with that design to theatre and applying this in theatre. I have to commend my fellow registrars at the time. They all bought into this concept. There was no animosity or anything like that. When I had cases, they helped. They all were involved, got involved. And this is Piet Maree, who's now a pediatric orthopedic surgeon, helping with a case that we are pre-building and going to theatre the next day and applying that frame. So all of the registrars were involved and all of the registrars helped. Now we experimented a little bit to try and make the flow easier. From all of you, what you see in theatre, what I do now, didn't come quickly or easily. That took years and years of experimenting on having a technique that is reproducible. I tried arthroscopy stirrups to try and elevate the leg to try and have enough space around there. That didn't go that well. So we're not using that anymore. But we tried many different techniques in trying to perfect the technique that I have now and I've used for the last probably 10 plus years. In the beginning, ankle equinus was a problem, and we had very low-tech solutions. This is just a collar and cuff sling to keep the foot from going into like a foot down. From there, I went to the workshop in the hospital and I asked them to make masonite foot plates for me that we tied to the front to prevent equinus. And slowly we progressed to the boots that you see nowadays, that's elasticated boot that patients can walk on. It's a lot more stable, a lot more secure, a lot more comfortable. So we had many, many iterations in perfecting the way that we do frames. So we continue doing cases like this. This was a very busy time for me. because, like I said, I started this when I was a second year. And as you would now go and do your subspecialist rotations, I would be in arthroplasty or in spines or in peds or something like that. All the other registrars would back up these cases and line up in a list somewhere during the week. And I would sneak away from what I was doing to quickly go and run a theatre and do 2 or 3 frames and then go back to arthroplasty or back to spines. So I always had to beg and plead from the consultants overseeing my rotations so that I can go and do frames all over the place, driving between 3 different hospitals to go and do cases. But we progressed and we saw good outcomes. So this is a patient with a tibial plateau fracture. You can see him after the frame application, video on the left, and this is after the frame has been removed, the video on the right. And he's got a very good outcome, almost normal knee function after a very potentially debilitating injury. I ran this picture past my kids and they said it's okay to show. This is another patient that we had. It's a youngster. He was 19 years old, pedestrian that was hit by a car and had a very, very bad plateau fracture. His knee joint was open. His extensor mechanism from his knee was ruptured off. So that was straight into the knee joint, and you can see the plateau fracture of the x-ray in the middle. Very, very deranged bony contours on the inside. Now this patient I remember distinctly because I was not on call, but I was called at about 9 o'clock at night by Alberto Pudu, who's now a spine surgeon, and said, I've got a case for you. I'm taking it to theatre tonight. Tomorrow you can take over and you can do your frames. So all the registrars would collect these cases and let me know early so that I can duck off and go and do these cases all over the place. So this patient had a frame, but because he had the soft tissue damage over the knee, we extended the frame across the knee so that the soft tissue can heal. This is him at the end. Once the soft tissues have healed, the knee joint, you can see flap to cover the knee joint, and you can see his functional outcome there with, again, a very bad injury with a very good functional outcome. And like we said, we progressed. I kept doing cases, kept doing more and more and more cases, seeing the outcomes that we had. And the time was to start presenting the results at meetings and at congresses. But I was still a registrar. And this is one thing that I can please ask everyone that's a consultant or registrars that become consultants, be kind when you are speaking to registrars. Because I did not receive, or the orthopedic community did not receive my results kindly. These were some of the comments that was made at congresses and meetings that I presented my work at. And again, these are consultants speaking to a registrar. So these devices are non-union machines that should never be used. Our patients will never tolerate it and you will get bad results. This is after showing my results. This, at a meeting the year following, it's like our patients can't look after these frames. With HIV that is so high in our setting, you'll see pin site complications and it'll be a disaster. And then this was at a congress, at South African Orthopedic Congress, and Len and I were presenting a paper together, and this gentleman wasn't joking when he made the comment at the Congress, like, this is a crime against humanity, and you should be reported to the Human Rights Organization for putting these devices on patients. So that is what I had to deal with as a junior consultant and as a registrar. But I saw the results and pushed through. And after this negative feedback that I got, I decided I'm going to go back to the source. I'm going to learn from the source. And I'm going to tell you his story and then carry on with mine. So if you want to talk about circular fixation and limb reconstruction, you have to talk about this gentleman, Gavriil Abramovich Ilizarov. He was an absolute genius. Ilizarov was born in Belarus in 1921. He went to medical school in Crimea in 1939. And after he finished medical school, he was sent to Siberia as a GP. Now, Siberia, or Kurgan in Siberia, is where Mark that off there. It's on the border with Kazakhstan, and I promise you, it is in the middle of nowhere. They didn't send captives there because they had big prisons or camps there. They sent captives there because if you escape, you die. There is nowhere to go for thousands of kilometers in any direction. There's literally nothing. Everything looks the same anywhere you go. So you don't escape because you die. And that was Siberia. And just as isolated that is, so Ilizarov found himself so isolated in his work as well. And he saw a lot of patients, post-war patients, coming back with a lot of bad injuries that he didn't know how to treat. And there wasn't technology to treat that. So he came up, and there's many stories of how he came up with it, but with this circular fixator with fine wires to hold bone together percutaneously. So in 1946, he started to develop these devices. In 1950, he registered a patent. In the end of 1950, November, he applied his first frame. And then a couple of years later, he became the head of surgery at the Kurgan Regional Hospital. And like I said, this gentleman is an absolute genius. Okay. Now, all went well initially, and like belief is nowadays, he also treated fractures that didn't unite by compressing them. And he developed these devices so that you can adjust it afterwards, and it actually shortens and it compresses the bone underneath. So the idea is compress the frame, compress the fracture site, and compress it until it unites. But he had a patient that got the instructions wrong, and instead of compressing, the patient turned it the other way and actually started pulling everything apart. Now, instead of him looking at this patient and going, how could you get this wrong? Show you how to do this. He actually went and studied the x-rays and found something, saw something that everyone else was missing. In that patient, after he was distracting that gap, there was bone in that gap, forming in that gap. And again, a genius is looking at something that everyone else sees but thinking about it differently. And he looked at this and said, there's something going on here. We need to investigate this. And he started experimenting on dogs. I'm saying it must have been a horrible time in the 1950s in Siberia if you were a dog, because you had frames applied and legs lengthened and lots of dogs running in circles with different legs. But anyway, he saw this potential. He saw into that gap, and he saw something that no one else saw. And that is what we call regenerate bone formation. It is a very, very specific artificial way of making bone. It is not a natural process. It's not how the body works. It is something different. It's something new that has never been done before. And we use exactly the same principles today that initial discovery came from. So this is a patient of mine that had a very bad fracture, he had a bone loss. We got him united, but the tibia is short, just like the femur patient. And we then went and applied one of these Ilizarov frames. You can see we cut the bone on the second picture, and then slowly distract those two pieces of bone apart. And by doing that, you can see in the third picture how that fills up with regenerate bone. And if you give it the right mechanical environment, that bone heals, and it's indistinguishable from normal bone. It's not scarred bone. It's absolutely normal. It's got a medullary canal and cortex, and it looks like absolutely normal bone. So did a lot of experimentation, wrote a lot of this up in the Russian literature, but was ignored in Russia completely. He was working in isolation in Siberia, and no one wanted to hear anything that he wanted to say. Wasn't allowed to present his work at meetings or anything like that. That changed because of this gentleman, Valery Brimmel. Now, Valery Brimmel was one of the best high jumpers in the 1960s in the world. You can see he's featured on the Sports Illustrated. He was one of the first sport superstars there ever was. He was invited to the US, even at the time of the Cold War, to the US, was on talk shows. He was an absolute superstar. He won the gold at the 1960 Olympics, and between 1961 and he won silver in 1960, jumping the same height as the guy who got gold. But between 1960 and 1963, he broke his own height record 6 times. and then competed in the 1964 Olympics and won gold. Now, at time of the Cold War, if you won gold at the Olympics, you were a national hero, well, in the US as well as in Russia. And that happened. And he's an absolute superstar, mega superstar in Europe and in the rest of the world. Now, he had a motor car accident in 1965, and he broke his tibia, and he ended up with an infected non-union. So a fracture that didn't heal, plus was infected. And because all of the academia was in Russia, in Moscow, was concentrated in Moscow, he was operated in Moscow by multiple different surgeons. And he had more than 20 surgeries to his tibia without success. So multiple, and they basically gave up and said there's nothing more they can do. One of the orderlies knew of Ilizarov and the work that he did in Kurgan. And while the doctors weren't listening, that was never allowed to be openly said. He basically went and whispered in Valerie Brimmel's ear and I said, listen, I know someone that might be able to help you. Come with me and we'll go to Siberia. And that's then what he did. So from Moscow to Kurgan, for me, that was a 3-hour flight plus another 3-hour car drive to get from Moscow to Kurgan. So Moscow, Chelyabinsk, Kurgan, 6-hour trip. Anyway, he went to Kurgan and he was treated by Ilizarov. You can see there he's got one of Ilizarov's apparatus in his hand, and he went on to be united. So he got him united, and he actually went back and he competed in the 1968 Olympics again. He obviously didn't do as well, but he said he wanted to go compete to say thank you to Ilizarov for what he did. So the fact that he competed was enough for him. And then, obviously, with Brimmel being such a national hero in Russia, when he got back and people saw he's united and he's back at jumping at the Olympics, everyone wanted to know how this happened. And that is where Ilizarov came to fame in Russia. And he became known as the magician of Kurgan. So now everyone wanted to see his work. He was now a national hero. You can see all the medals typical for a Russian state. But like I said, he was very, very famous, but still only in Russia. This was a time behind the Iron Curtain. No one in the West got to know about any of the work that he did. We needed someone else's story to make that happen. Now, Thor Heyerdahl was a Norwegian explorer. He did the original Kon-Tiki tour boat expedition in 1947, and then in 1969, 70, 77, he did a couple of additional expeditions. Now the Ra and the Ra-2 expeditions were from Morocco to Barbados. The first one in 1967 didn't work, was just before Barbados. This was a papyrus ship, broke up the transatlantic trip, and then repeated the trip in 1970, and made it to Barbados. Now, he assembled a team, a multinational team, and he did that on purpose. He wanted people from all over the world to be his crew. He didn't want anyone from the same country as his crew. So you can see the flags that's on that ship. Every member of his crew was from a different country. And it just so happened that he had a Russian doctor, so this is the Ra-1 and Ra-2 expeditions, and then the Tigris in 1977 went from Iraq to the Red Sea. And just so happened that the crew that he's handpicked included Carlo Mauri, who was an Italian photojournalist, who had a ski accident in 1960, again had an infected tibial non-union. You'll see in all the pictures that you see from these expeditions, he's wearing the long trousers. Everyone else is in shorts. So he's got his infected non-union with dressings under his pants. Another member that was handpicked by Thor Heyerdahl was Yuri Sengrich, who was a Russian physician. And Yuri, in his expeditions, do the dressing changes for Mauri's infected wound every day. And on, don't know in which trip, but in one of the trips he said, listen, come with me. I know a guy in Russia that can help with this. That's what he does. And Mauri, again, he was treated by some of the best surgeons in Italy, who couldn't get this non-union healed, he said, all right, fine. So in 1988, he traveled from Lecco in Italy to Kurgan, and he was treated by Ilizarov. Same way, basically the same treatment that Rimmel had. This is a very interesting photo. This is Mauri and Ilizarov both having a smoke in theater before the operation. Suppose just to calm the nerves a little bit. But anyway, so smoking maybe is not that bad for limb reconstruction. Anyway, so this is one of the famous photos. I think this was at the end of his treatment. So again, Mauri's treatment, he equalized his limb length, he sorted out the infection and he got it to heal. He also had a equinus contracture, which he fixed with the frame as well, and got that up. Mauri went back to Italy, where he was friends with some of the big wigs in the Orthopedic Association. So this Bianchi Maiocchi was the Italian president of the AO, and then Roberto Cattaneo and Maurizio Catani were both surgeons in Lecco. And he went back, they heard his story, and they said they want to go learn this. So they traveled to Russia and brought some of the techniques back to Italy. But again, was stuck in Italy, typical Italians, where they worked on this and they published on this, but it again didn't really spread further from there. To spread it to the West properly, we need to thank this gentleman. So in 1986, Draw Paley was in 84 first, he was a resident. And he saw a presentation when he traveled to Europe on the Ilizarov technique by one of the Italians, and he said he wants to learn this technique. And he traveled to Russia as well to go and learn the technique from Ilizarov himself. A remarkable individual. He went for 3 months the first time, noticed that too much is lost in translation, went back to Canada, studied Russian for 9 months, went back to Kurgan and could communicate fluently in Russian with them after 9 months of just studying Russian. He now speaks something like 7 or 8 languages. Really, really remarkable individual. But anyway, it's thanks to him that this technique went back to the US, and from there, the rest of the world. So in end of 2010, I decided to go to Russia myself, and like I said, go and learn from the source. At that time, I had everything that I could find. There's nothing more that I could read. I couldn't find any more literature to read, so I needed to go and ask questions myself. So I spent a couple of weeks there in Kurgan. It's a dedicated 800-bed orthopedic hospital just dedicated to the Ilizarov technique. And I learned quite a lot from my time there. And it shaped a lot of the work that I do now, and why I do things the way I do is from the stuff that I learned in Russia. So I returned back to Pietermaritzburg. We continued using circular fixators. Here you can see Len Marais, who's the president of the South African Orthopedic Association. We were working together at the time. And Len has got such an analytical mind that he helped shape a lot of the things into a reworkable package at that time. So again, we went on and perfected these techniques that we've learned and been practicing over the last 4 or 5 years. So then back to these comments. If you told me before I became a registrar that I would end up in academic medicine, I would probably laugh. This wasn't a planned destination. This is something that happened along the way. And probable reason for it is that I don't like these, or didn't like these negative comments, and basically went into research to spite everyone that doubted this technique. So started off with these on non-union machines and should never be used and should have bad results. So the first was, okay, I'm going to shoot that out of the water, and I published on the functional outcomes of our patients that we treated. So specifically looking at tibial plateaus and knee dislocations and things, and looking at the functional outcomes. Right? So that was sorted. So the patients actually do well, and these heal better than plates and nails for those same injuries. The next was, well, our patients can look after it, and pin site infection will be a problem, and HIV definitely is a huge thing. It's like, all right, we'll take that on as well. So published on my pin site protocol on how to prevent pin site infections, what our pin site outcomes were, and then also specifically looked at the effect of HIV infection in pin site infections in 229 patients and found that there's absolutely no difference in outcome in patients with HIV, positive or negative, as long as they're on treatment. They had exactly the same complications and the same severity. Now, the last comment I didn't really know how to approach, but in this case, basically just kept plugging away at it and just publishing what we did. Publishing what we did and publishing our results. And that just kept going and going and going and going. And I don't know when it's going to be enough to show this original comment that this is a valid treatment method. The other thing that I can also say is you've really seen this patient with the outcome of the non-union, but I don't think it's too bad for the patients. They tend to tolerate these devices quite well, and laughing away and walking away. So not all of them are like this, but it's not too bad for patients. In any case, this is where my love for non-union management started. My intrigue with non-union management started. And it is just such a diverse pathology with so many different things to consider. No two are alike. And it takes the nuance, understanding the slight nuances of these cases to get them to heal. In this, I learned a phrase from a great recon surgeon, Knut Christensen from Denmark. And he introduced me to the concept of mechanobiology. Now, we all know biomechanics. This is mechanobiology. And this is the science of how mechanical forces changes the biological environment in a body. So, and this goes down to a cellular level and a subcellular level in bone. So this how the biology changes. And my whole approach to tibial non-union management is based on this concept of how mechanical forces interact with the body at a cellular level. So we looked at atrophic non-unions, so mobile non-unions where there's not a lot going on. And I use a very specific device in a very specific way to stimulate that healing. Here you can see a patient with a little bit of a defect, but it's an atrophic non-union. So just compress that, get some stability, have a frame that can stimulate bone formation and that goes on to heal without needing bone graft, which again, the fallacy was all of these needs bone graft. That is not true. You can get it if you give the patient, the body, the right mechanical environment. The biology follows the mechanics. This is another case, again, very bad. This is the patient I showed earlier, very bad injury. The X-fix that he has on the left was great for initial management for this patient, but it's the wrong device for managing a non-union. So that fracture didn't unite, and again, change that device to a device that gives you better biomechanics, and let the patient start weight bearing again. There's the picture in the middle, no bone graft or anything. This is just changing the mechanical milieu, and the biology follows, and the patient goes on to heal. And then wrote quite a few papers on specifically mechanobiology in non-union management. Also published our treatment algorithm. On the stiff non-union side, and this is going back to the first case that we saw, this is where you take a non-union that is trying to heal, but it doesn't quite get there, and it is stiff, it doesn't move, but it's painful for the patient and it's not united. And the idea is that you distract these and you do not compress them. You don't need bone graft. All you need is a constant distraction force across that non-union site, and you can get this to heal. It is, like I said, it seems counterintuitive, but it can be explained quite easily. So if you have the ideal strain environment, now strain is the movement over fracture site over the size of the fracture site. So the movement over the gap. In the gap of every fracture, there's multiple cells, pluripotent cells. Those cells can make cartilage, they can make bone, they can make fibrous tissue. It's the mechanical environment that selects out the cells that can survive to make that tissue. If you have the ideal environment, where the cells are not stretched too much and the vascular supply isn't stretched too much, you can get bone formation. If you have a very high strain environment, like a very small gap with lots of movement, the cells that make bone and the cells that make cartilage can't survive this. It's also a low tension oxygen environment, which means that all of this favors fibroblasts, and you end up with a fibrous non-union. The body tries to heal, but there's too much movement, so there's more callus that forms, and you get this expansion of that callus volume. It gets more and more and more and more for the body to try and stabilize the situation, but it just can't get it right. And you end up with this classic, what you call a hypertrophic non-union, or elephant's foot, or a horse's hoof type non-union. And that is just the body's attempt to minimize movement. And if you look at histological slides, that's exactly what it looks like on histology as well. A fracture that's not united, but lots of new bone formation on the outside. Okay, if you now go and look at the mechanics of this, we have a high strain environment. So delta L, the movement of your fracture site is high. L, the fracture gap is small. And that gives you a high strain environment, favoring fibrous tissue formation. If you put an X-fix across that fracture site and you stabilize that bone, you decrease delta L. So the movement goes down. And if you now put a slight distraction force over that, you increase L. And the combination of those two decreases strain. And if you decrease the strain between 2 and 10% across a fracture site, bone forms. So this is why distraction works for these non-unions. There's a clear mechanical explanation for it. Now, back to the comment that I got. Like I said, the first comment of my paper, I wrote back probably a response to that first comment that was longer than the article, with references in explaining this. And to the credit of the reviewer, obviously read through it because the paper got accepted. And this was the anchor paper of the PhD that I did. This combined with a whole bunch of other papers on non-unions made the PhD. And the final result was publishing the flow diagram of the treatment, and our outcomes over the PhD was 122 tibial non-unions that was treated according to this algorithm with a 98% union rate, which, I don't know what this picture's broken there, but a 98% union rate, which is pretty good if you talk about non-union management. And like I said, that is the PhD that I also got. A lot of people go and say, well, this is distraction osteogenesis. This is like lengthening that limb. You're just making new bone with that. I don't believe that to be true either. That is what distraction osteogenesis regenerate bone looks like. This is what bone looks like if you distract the tibial non-union. They are different types of bone formation. And I think it is a pure mechanical explanation rather than a distraction histogenesis. And again, to explain that with one of my previous fellows, we went and wrote out the mechanical theory for how this works, and this has been published along with a couple of other non-union papers. This doesn't only apply to X-fixes. If you understand how non-unions work and you understand what is missing and you understand strain, you can easily manipulate any fracture that's difficult to heal by just giving it what it needs. Classic example of this is our arthroplasty surgeons who shouldn't nail fractures. So they had a fracture of this patient's femur through a pinhole for navigation. Nailed it. So nail's not too bad, it's just giving them. But you can see that this developed a hypertrophic non-union. So again, fracture gap small, lots of movement around that fracture gap. What you want to do is you want to bring the strain down. And without doing massive operations, exchanging the nail, which you could do, you just go and put a plate over that non-union site, which decreases that strain in that environment, and the patient goes on to heal quite quickly and quite easily. So that took me to the end of my training. I actually came here before my PhD was awarded. I had to fly to go get my PhD. But I made the move to Cape Town in 2016. And thanks to Prof. Toy, started the tumor sepsis and reconstruction unit. There was recon work being done here, but it wasn't grouped into one unit at the time. So I came here and started putting it all together and putting the resources in one unit and getting all cases concentrated in that unit. With this type of work follows, and work from all over Africa follows. And these are just some examples of cases that I've had from our neighboring countries. And again, patients that have to make long journeys and travels to get their limbs sorted out. So these are cases, this is a patient from Mozambique. We actually have seen a couple where they don't have a lot of surgical opportunities. And we often see patients with malunions like this, so very short, angulated, very rotated. Patient can't function like this and they need recon. This is another patient that came in. This is not a way that we would treat femur fractures in adults. This is a more pediatric approach, but the surgeons there do what they can with what they have. And this patient ended up, you can see that femur isn't straight. So it came to us, took out those implants, revised it to a different fixation device, and got that leg nice and straight, and the leg lengths are almost equal and pretty good. This is a patient from Malawi that hitchhiked over 3,000 kilometers with bilateral. This is one side, but he had both tibias looked exactly the same. And he basically had a 90-degree malunion of his tibias. So he had his injuries, he was just placed in a bed because there aren't surgical expertise. And this patient, like I said, he hitchhiked down to South Africa for someone to help. And we managed to get him straight and go back home. This is a patient from Zimbabwe. He also, just to illustrate that people try, 38-year-old, he had a closed femur fracture. He had an operation in Zimbabwe, and he came to us complaining of pain and deformity, and they weren't helping him further. And this is when he came to us, and you can see those plates are pulled out, and the fracture is unstable. But why I'm showing this case is that this is what I took out of that patient. And if you look carefully, those are normal woodwork screws that you go buy at a hardware store. And a lot of people say, how can you do this? If those surgeons don't do that, those patients get nothing. They get traction. So they try. And I hope that they get it right more than they get it wrong, and that a lot of patients actually go on to heal. And the ones that come to us are the ones that were unlucky. But anyway, this lets you think on your feet when you need to take these screws out in theatre and you don't have a normal screwdriver you have in your garage. So yeah, to get this out and then just fix like we would normally do with a nail, and that goes on to heal again. This is a South African that... no, sorry, this is not. So this is another patient also from Zimbabwe. He was a 27-year-old motor vehicle accident quite a while after his surgery, and he complained of pain, deformity, and infection in both his femur and his forearm, and presented to me like this. So that's what the forearm looks like. You can see screws falling out. You can see the bone ends don't look great. On the femur, you can see, I don't know what's happened there. There's broken drill bits, bent nail. The fracture's in a good position. And both of these were infected as well. So we take it one by one. The forearm went, this was staged, but it ended up replating the radius, replating the ulna, doing a Darrac's procedure, meaning we make a gap between the ulna here and then fuse distally at the wrist. So now the rotational movement happens at that gap and not at the wrist. So it's called a Swaf-Kapanji procedure. And he ends up good function, elbow, wrist, hand, and he's infection free. And on the femur, we went in, took out that bent nail, revised it to a different type of nail. Patient goes on to heal. We later took out the nail and did local antibiotics and treated his infection like that as well. So forearm fixed, femur fixed, back to Zimbabwe. This patient is a South African, but he's a truck driver, and he was in an accident in Botswana. So 43-year-old man, truck driver, very bad injury to his elbow, and the only thing he asked me was, I can do whatever I want. He wants to be able to drive trucks again. So as long as he's got an arm that he can drive trucks. Now, he had a very bad open injury, basically lost the elbow. The elbow joint is gone, somewhere on the road in Botswana. He was treated by the surgeons on that side, by debridement and an X-fix. And when they didn't do anything further, he said, all right, he wants to go back to South Africa for help. The surgeon said, fine, but you're not going with our X-fix. So they took him to theatre, took off the X-fix, put these KYs in and said, all right, now you can go, now you can leave. So he rocks up with us like this, and just to give you an idea of what it should look like, okay, all of that is missing. So the distal humerus, the proximal ulna, everything is missing. So the elbow joint is no more. And that's the soft tissue that he presented to us with. So there is nothing in a book to tell you how to treat these. It doesn't exist. You have to make a plan. What I did was I took an X-fix hinge that is completely off-label use, but a lot of the stuff that we do are. A hinge that is supposed to be on between the rings so that the rings can move relative to each other. And I took that hinge and I wrapped it in antibiotic-loaded cement, and I put the one end up the humerus, the other end down the ulna, and then wrapped the whole hinge in more cement. So the whole hinge in more cement so that the hinge can't move. So now the hinge is solid, but it's in the bone, so it stopped translation of the two bones relative to each other. Then stabilized over all of that with an X-fix as well. So now we want the soft tissue to heal. So this is his X-ray. This is all cement with this hinge that's in the medulla of the medullary canal of the ulna and on the humerus. 6 weeks later, the soft tissue looks like that. Everything looks good. We are winning. And I went back in, took the hinge out, took the cement out, put a new hinge in that didn't have cement, and then bone grafted around that new hinge. And you can see there, this new bone formation around this hinge. And the nice thing about having a hinge is the patient can come back and tell us the position that he wants the arm. So he actually came back to the clinic one day and said he wants the arm a little bit more extended than we would normally do, because he says in that position he can hold on to the steering wheel of the truck while he's changing gears. So we extended his elbow slightly and he was happy, and that went on to heal without infection. Nerves in his head, all is fine, and he's actually back driving trucks. All our patients don't all come from far, but a lot of patients have a long story before they get to us. This is a 23-year-old gentleman, had a polytrauma patient as a child. Very, very bad head injury, so very low function. But he had severe injury to his femur and to his tibia. So his femur is short and deformed, his tibia is short and deformed, he's got an equinus contracture, and he can't walk. This is a flail leg that is just flopping in the air. So we said, all right, we can stepwise try and see what we can do. So we'll start off and we lengthen the femur. So we use a special nail that's got a male-female component that slides, so it's telescoping apart, and you actuate this from a device on the outside of the skin. So as you put that on the skin, it rotates a little magnet inside the nail. That magnet rotates a gearbox, and the gearbox pushes out the telescoping mechanism, and you can see how the femur lengthens. So I said, once the femur is out to length, we'll start addressing the tibia, and we got the foot so that it's plantigrade, got the tibia straight, and got the length restored of that tibia with a frame. His leg isn't perfect, but it's a lot better than when we started. And this is him progressing, again, starting to walk on that leg without his brace. And at the end, before we discharge him, not playing. Sorry, the video isn't playing. But he's now walking without crutches or without a brace, and carrying on. Another case, 14-year-old was treated by the other orthopedic surgeon. She had deformities of her legs and she had growth modulation, meaning you put little implants inside that stops the growth plate on one side, let the growth plate on the other side grow so that you can change the shape of the leg. They tried to remove the implants. On the one leg, managed to do that. On the other leg, broke it, and I think damaged the growth plate. It grew, and this leg grew skew, and they kept going back to the surgeon, and at this point, the surgeon said, there's nothing more they can do. They must live with it. That's it. They can't do anything else. That is where they ended up at my clinic, and doing the analysis of this leg, you'll find that there's a deformity in the femur, and the femur is short, and there's a deformity in the tibia. So we have to address all of this. So this is part of the planning. This is virtual surgery planning on the top, and you can see my actual execution on the bottom, so got very close. And then we want to lengthen the femur, and we want to straighten out the tibia. So this patient needs 3 implants, a plate for the distal femur realignment, a nail for lengthening the femur at the top, and an X-fix for fixing the tibia alignment and length. And this is her at the end. So the leg is straight and realigned. Another example, 19-year-old growth plate. You can see the femur is very short, deformed. So we did an acute realignment with a nail and lengthened him out again with that same nail. And this is his final outcome. With the leg now being straight. This is another example, growth plate injury of the kiddie. This is what actually Maria and I did together. Very, very bad injury, damaged the growth plate a couple of years earlier, so the legs grew skew. You can see that he was being teased at school. And,
actually see if we find a different place to do this.
Yeah, sorry, Marie. Anyway, so that was the plan for the surgery. So we planned, again, digital planning on how we're going to do the correction. That is in theatre, how we now execute our digital plan. That is the planning of the plating and what it must look like when we're done. That is then done in theatre on the right. And again, got the plan, got what we planned in theatre. This is immediately post-op, so now the leg is straight, but it's short. So we'd use a nail at the top and we lengthen out the femur with a nail there. And you can see this is his outcome at the end. So leg is straight and realigned and he's walking normally again. I'm almost finished with examples, I promise. This is an interesting one. This is an 18-year-old with Ewing sarcoma of the pelvis, and she had a resection of her hemipelvis, lost half of her acetabulum, and had an attempted arthrodesis of that hip, so to fuse that hip. The arthrodesis didn't work, and she had pain. But she also she was functionally short because the hip was sitting so high. The femur length and tibial length is normal, but the hip is 6 centimeters higher than normal. So we said, well, we can easily lengthen a leg, but the problem is we don't know if that hip is going to be stable enough, and this is Maritz Loubser from UCT that actually taught me this, is to do a flamingo view, so the patient stands on that one leg, and if the hip doesn't move while they have full weight just on the one leg, you can go ahead and lengthen. So we went in and lengthened her femur 6 centimeters. Now, she doesn't have half of a pelvis, and we've lengthened her out, and she is comfortable in this position. The hip obviously isn't normal. And she went on to be an exchange student to Germany and lived in Germany for 6 months after this whole story. Another example of where we are pushing the envelope a little bit in recon and where the field is moving. We had a patient that referred to us from the Eastern Cape. She had a femur fracture that was fixed, became infected. Implants were removed in the Eastern Cape and referred to us and see if we can help her. So this is now infected non-union of the femur. This was necrotic bone that was resected, and I replaced that bone with a cement spacer that was antibiotics in it and a plate. and now she can rehab because that leg is now stable. What we did next was do a CT scan, and I sat with the engineers in Stellenbosch and said, all right, this is the defect that we're going to create. I want to put a nail up that femur, and I want you to design an implant that can fit into that hole. And this is what they came up with. So this is a 3D printed titanium truss with cutting jigs to help us exactly make everything fit. This is us rehearsing the surgery with plastic trusses and plastic bones of the patient. And we rehearsed that operation. Then went to theatre. That's when you can see the infection is now cleared up. Took out that plate, took out the cement spacer, put in that truss with a nail, and that patient can go back to the Eastern Cape and don't need any additional surgeries to manage that femoral defect. And in all of the work that we do, we see a lot of infection, and a lot of the stuff that we do is similar to in the rest of the world, but there are some slight differences. And we've published our approaches on almost all aspects of infection management, bone infection management, our protocols, our antibiotic regimes, all of that has been published. So this is just on infections. What is really nice, one of the premier bone infection units in the world is the Oxford Bone Infection Unit, and Martin McNally is the guru in infection management. And after one of the papers that I published, this is what he wrote to me. And he says, a very nice study. He will certainly be quoting that in future. So the big wigs are reading our research as well, which is really, really nice. One of my hobbies is also managing bone defects, and that is where those trusses come from. This is a homemade design between us and the engineers and manufactured locally. And so bone defect management is, again, one of my passions, and we've got a specific approach on how we do this, and all of this has been published as well, and a specific classification system that was developed here as well that we use. Then also published multiple clinique articles on devices. The last paper here is defining anatomy that wasn't really defined previously with the population, and actually found the range is much tighter than is published internationally. And like I said, also a lot of approaches and surgical techniques being published. The one that we've now for the last three years, all the registrars, they would probably not even know what a monolateral cross ankle looks like anymore. We use circular fixators to span ankle joints, and got a specific way on how to apply that. And this was published as well in Injury. And they are now teaching that specific technique in courses all over the world. So this is 2 weeks ago in England, and you can see the paper, our paper is there, and they use that paper to do their workshop. And this is one of my good friends, Alex Vris. He was actually in Russia with me, training people in Turkey in how to do our frame. So our frame is being applied all over the world now. What's his name? Steve Mitchell actually sent me pictures in their hospital in Bristol. They have sets labeled Tigerberg sets for doing cases that he saw here. So apart from the research going out all over the world, I've also been very fortunate to travel all over the world because of the work that we do, and recon becoming so popular in the world as well. So these are all the congresses that I've been invited to give invitational lectures. Sorry, they're supposed to be all of this now. So I've been to all of these congresses as an invited speaker over the last couple of years. And if you then add in all the places where I've been as a faculty on courses and do training, I've really been incredibly fortunate to travel all over the world to go and do lectures, present our research, and do training. So that's the thing. So going out to the world, mingle with people, sharing of ideas, and I've stolen with my eyes a lot and brought ideas back here that have implemented here. But additionally to that, because of the name that our faculty, our department has internationally as well. We also see a flood of international surgeons coming to us. And you can see this is just from all over the world, people coming to visit and coming to see what we do and learn how to apply frames, in addition to all the other work that we do in the division of orthopedics. And then one thing that I'm incredibly proud of is the fellowship. So I've up to date trained 9 fellows, and you can see also a bit of a diverse group from all over the world have come and spent a year with us, trained in limb reconstruction, and have taken what we've learned, hopefully, have learned here and actually go and implement it elsewhere. So that's a really, really rewarding aspect of my work. So in a 14-year academic career, I had a quick calculation, done about 4,000 frames, 157 publications. Like I said, most of that is just because I'm stubborn and want to prove people wrong. 8 book chapters, sponsored 27 MEDs with 4 ongoing at the moment, 1 PhD completion with another 4 currently. And this is just my publication history at the bottom, and you can see the blue is local, green is local, national collaboration, and the orange is international collaboration. And you can see how, with time, the international collaboration with research is just getting better and better and increasing and increasing. That dip in 2017 is because I didn't have any patients when I moved here in 2016, so nothing I could publish. Yeah, and like I said, the move here to the Cape has been a brilliant one, and something that I have to thank Prof for the opportunity. And then in 2017, got awarded the associate professorship, and in 2020, full professor. And just to cap all of this off, last week I came back from Baltimore, and I was invited to be an instructor at the Baltimore Limb Deformity course, and it is the premier deformity course in the world. And having been invited there as an instructor, table instructor and lecturer, also something that's I'm really proud of. Thank you very much.
Good evening once again, Professor Nando Ferreira, to the Ferreira family and friends, Professor Elmi Muller, our Dean for the Faculty of Medicine and Health Sciences, to our university leadership, to the leadership of the Faculty of Medicine and Health Sciences, ladies and gentlemen, good to see all of you here today. It's an absolute privilege and pleasure to be with you tonight and to be part of and share in this inaugural lecture, which is effectively the introduction of Professor Ferreira and his academic scholarship and interest to the academic community in Stellenbosch University, but also to our community at large. Now, as has been mentioned a bit earlier, the inaugural lecture is a typical rite of passage event within a university and marks the recognition of a colleague that's been promoted or appointed and enters the ranks of full professor. So in the case of Professor Ferreira, it was in recognition of being bestowed the rank of full professor. It took place some time ago, but I think, the challenges of COVID obviously means that's a bit of a backlog in this particular faculty. Now, this event afforded Professor Ferreira to share his innovative ideas, his discoveries, his deep insights with regards to his discipline focus and his academic scholarship and interest, and we saw all that this evening. In the case of your lecture tonight, Professor Ferreira, you shared your journey, the entire journey in you becoming a professor. So thank you very much for your lecture on travel and transformations, stories in limb reconstruction. I have to say that you've given me new insights into construction. I had no clue about this. The one thing I'm sorry about is that I'm a chemical engineer, a mechanical engineer, so I didn't understand some of the stuff that you were talking about over there. It's extremely thought-provoking in terms of what you presented to us tonight. Your insights and the patient's stories were life-changing, and they are truly inspiring. Now, one indicator of a good inaugural lecture is the ability of a professor to share deep and complex disciplinary knowledge in a manner that is both understandable and thought-provoking to the general audience, but also clearly articulates the novelty and the complexity of the work of disciplinary experts. Now, this is an incredible balancing act that you have to undertake, and you've done it impeccably well tonight, to say. You have shared this through your woven storyline, and this is the art of a true professor, a real philosopher in terms of the way you went about telling that story. Professor Ferreira, you have distinguished yourself in both the clinical area as well as in academic research. And you have an excellent record in both of them. I've also been told a bit earlier tonight that you're the first professor of orthopedics at this institution. So congratulations. I think a real achievement in that regard. So congratulations on your body of research, your work on limb reconstruction. Your work does not simply add to academic knowledge, but truly changes people's lives. You mentioned in one of your slides, you do magic. But I can tell you what, to your patients, you're not a magician. You're a medical worker. We are proud of you and your work and your achievements. You mentioned a bit earlier the struggles that you've had in terms of having to publish and get your work recognized. But all I can say is that when you're a pioneer, you have to be and you have to have absolute self-belief in yourself, even when others don't. And your journey epitomizes that, the total self-belief and the attributes of being a true pioneer in your field. I can end off by saying you epitomize what it means to be an academic of this institution. You epitomize what it means to be a professor at this institution. It speaks to the vision of Stellenbosch University. You are in service to society through the work that you do, changing people's lives on a daily basis. I invite you to come up and collect your scroll. Thank you very much.
Thank you, Professor Ramjuganath. Nando, all I can say is that it would be a crime against humanity not to do what you're doing and to not help people like you do. So thank you very much from my side also. Colleagues and friends, I trust that you also found this event as enriching and captivating as I did, recognizing the true impact, the profound impact that dedicated scholars like Nando has on the society, on their patients, on our people of this country, of this continent, and the world at large. So before we end the proceedings, I would like to express our gratitude to the organizers of this evening for their hard work in organizing this event. Our sincere appreciation goes out to the entire team for their hard work, the team from the Inaugural Lecture Working Group, Ms. Megan Salon and other members of the team who are here this evening, whose meticulous planning ensured the smooth execution of the event. Our heartfelt thanks also to our colleagues in the audiovisual assistance team, in the campus security, facilities management, corporate communications, marketing, and the members of the registrar's RC for their invaluable support. Lastly, to each and every one of you, colleagues, friends, family here in person and online, your presence here tonight to celebrate this occasion with Nando and us is greatly appreciated. Thank you very much for attending, and I now invite you all to come enjoy some light refreshments with us in the Dean's reception area just down the passage. Please enjoy the rest of the evening and please drive safe. Thank you. Could please rise for the procession. Thank you.